So I want to welcome all of you. Very nice, thank you. Now it's gotten nice and romantic in here for our lecture. I want to welcome all of you tonight to our first Alight Night of the year. We are so excited to have four fabulous presenters. I first want to tell you a little bit about who we are and what we do. I'm Melissa Vogelsinger, and I'm the Executive Director of the Alight Foundation, which is a nonprofit here that's actually housed in the Cancer Center, right around the corner, in fact. So now that you're on this floor and in this auditorium, if you didn't know, we're right around the corner on the other side of the lobby here. And so what we do, we support the patients in the Cancer Center by providing emotional support in a variety of ways. One of the things that we do, we give them educational materials and resources at the time of diagnosis, often at the imaging centers when they first get the news that they've been diagnosed with breast cancer, so it takes a little bit of the fear out. They're able to get information about who the physicians are and the things about breast cancer that nobody knew the day before they got the diagnosis. Also, we have an emergency assistance fund that the patients that have been helped with this fund will certainly tell you that that often comes at a crucial time when they're trying to cope with their disease and they don't really have the stamina or the energy to face the financial challenges. So we're really proud of that. We contribute all of the money that goes to the breast cancer assistance now at Cone. That's been changed this year. It used to be that Cone paid for part of it. Now we contribute all of that money so that Cone is able to free up some of their funds for other cancers. So we like to think that we're helping breast cancer and other cancer patients. We also we added a Alight Guide peer mentoring program that was already in existence. We sort of adopted it here at the Cancer Center. It is a wonderful program. In fact, many of the Alight Guides are here tonight, and I appreciate all of you coming and certainly the work that you do with the women that are diagnosed. Sort of mentor them through the process of cancer, help them with practical coping tips and that sort of thing, more the emotional piece of breast cancer. We also have 3 support groups here at the Cancer Center that we are providing funds for the facilitator. She's been doing this for over 15 years, and I think that those of you that attend support group, many of those women are here tonight as well. It is a valuable piece in the journey and helping patients improve and get better and have a more positive outlook and attitude and sort of see hope and life beyond where they are at the time when they're going through it. We also are starting a new patient orientation where we're going to, as a survivor, speak to patients from the front end and kind of give them materials about the support programs and services here at the Cancer Center, and also just to get in front of a patient at the beginning of their journey with hair and health and say, I had breast cancer, I've had a bilateral mastectomy, I've had 33 rounds of radiation, 6 rounds of chemo, and look at me, and you're going to be okay. And I think that it's very powerful to patients, and so we're working right now to make that happen and sort of introduce the support programs to the patients that we that we offer and that the Cancer Center offers. We try to facilitate getting the patients to drive them to the Cone programs as well. And now, of course, the quarterly Alight Nights, which you are fortunate enough to get to be here with us tonight for this fabulous presentation. I think that this idea of the dense breast tissue was a fabulous topic to start with. We hear a lot about it. I talk to patients every day, and I go to the support groups, and there's just so many questions about imaging. And people ask me, and just because I happen to work in this building certainly doesn't mean that I know, but we have brought you the people that do know, and they're going to be able to really answer those questions and give you some insight into how to best take care of your own breasts and breast health. Just have to go to my notes. I want to tell you really quickly, what you may not know is that every week a team of doctors meets at 6:30 in the morning to talk about the patients that have been diagnosed with breast cancer and to update those that are going through treatment. I just find this as a patient so impressive. I sort of mentioned that I was a patient 7.5 years ago. But when I kind of understood this, and then more importantly, when I visited this group, I am so impressed with not only the fact that they get up at 6:30 and make it over to this meeting, but they're looking at complicated stuff early in the morning, and they talk about the pathology and the imaging and all of the different aspects of a new diagnosis. And they sort of discuss what is the best course of treatment among all of the different disciplines, the surgeons and anybody, the genetic counselors. I mean, really, it's a lot of people. And so I say that because I know that many of you are breast cancer survivors, and I know you probably already know what a fabulous medical team we have here, but I just want you to know, if you haven't had breast cancer, maybe you're here to support a friend, that you can be assured that they have received top flight care here in Greensboro. I always say, I think that you could go a lot of places, but you can't do better, and this is so nice to have right here at home and be able to be treated where you can be with your families and that kind of thing. So that group is called the Breast Care Alliance, and I say that's a very good segue into the introduction of my next speaker. These physicians that are going to be speaking tonight, Dr. Brown and Dr. Bertrand and Dr. Magranat, are all part of the Breast Care Alliance. They're also all part of the Alight Foundation Board of Directors. Dr. Magranat serves as a medical advisor, and the other two serve on our regular board. And so we so appreciate their service. We appreciate their time in doing this for us tonight. Honestly, I have to get my paperwork out to introduce Dr. Magranat, mainly because I will brief you, because you can see in your guide book there's a saga about his accomplishments. But I will be brief and hit the high points. And he's actually tells me tonight he's going to be moderator. He's not really presenting. He's sort of going to keep the ball flowing and make sense of how we're putting all this together for you. And he tells me he's going to be comic relief, so I'm challenging him to that. I think we're all thinking that ought to be good, right? Okay, so he received his undergraduate degree from Harvard, and in case that wasn't enough, he received his medical degree from UNC Chapel Hill. He completed his internal medicine internship and residency training at Duke, and followed that with a fellowship in hematology and medical oncology at Duke also. He's only 40, isn't that weird? Anyway, and most recently, Dr. Magranat completed a master's in pastoral studies from Loyola University, which he probably didn't have to do, because I think we all know how absolutely very caring and compassionate the man is, certainly if you've been a patient, which I was. He has a wife, Mary, and he has a son and 2 grandchildren, but most importantly, I think, and he will tell you this too, he has Sammy. And Sammy is the therapy dog who comes to the Cancer Center periodically on Wednesdays to cheer the lives of the breast cancer patients and other patients in the building. So, without any further ado, let's introduce the man of the hour, because he is the man of the hour.
Thank you very much, Melissa. I cannot tell you how much Melissa does for us and for you and for everything that happens here. She listed all the things that Alight does, but that doesn't really even come close to letting you feel what Alight actually accomplishes for our cancer center. So I'm the comic relief, and I thought I would go back to this picture, which is the picture of our morning conference. And there are several very shiny areas there. And I wanted to point out, this one is mine. That's Dr. Carr, you know. And I recently was taped for, they're doing a little thing for our, a video for our website, and they put a little powder on my head, and I couldn't understand why. But looking at this picture, I can see why. That's what's going on. Now, let's see if I can do this. This is the Cancer Center. This is the parking lot. This is more parking lot. The hospital is here. This little 2 acres is the only piece in this campus that wasn't built and built over. And the reason it couldn't be built over is because it's a watershed. So legally you couldn't build it. So when you see that, you think, well, it's just a waste. It's just a waste. We could have put more parking lot there. That's what maybe I would have thought. But perhaps if you are a woman and if you're a little imaginative, you say, you know what? We can do a lot with those 2 acres. So a lot is happening with those 2 acres, and you'll learn more about it later today. But I wanted to bring up the fact that it is women who do these things, because guys are different. The number of prostate cancers and the number of breast cancers are almost identical. The amount of deaths from prostate cancer and breast cancer are almost identical. But there's more research for breast cancer, about 6 times, than for prostate cancer. So why is that? I think really, classically, you tell the guy, you know, you got prostate cancer and you gotta get these treatments, and the guy says, gee, that's terrible, doc. Let me change the channel, because it's a football game here, and I'll come back to you maybe in a couple of years. You tell a woman you've got breast cancer, she wants to know. She wants to know what it means. She wants to know what she can do. And if you don't give her a lot of information, she might get mad. And if she gets mad, she might do something about it. Like, she might go and talk to the city council, or she might go and talk to the legislature, and she might get laws passed. That's what happened in Connecticut with a woman who didn't realize she had dense breasts, and then was told suddenly she had stage 3 breast cancer. She got very angry, and she got the first laws passed so women would be informed by law that they had dense breasts. We have a local person here, Addie Jeffrey. If I were to tell you all the things Addie does, we'd be here all day and all night because it's incredible. But one wonderful thing she did was she got mad. So I'd like her to tell us the story.
That was a heck of an introduction, wasn't it? Well, yes, I got mad, but I think I used it and channeled it in the right way, if you will. And I do want to start by saying that this is kind of emotional for me today, because it's kind of a full circle moment, because to be part of this event tonight with 3 doctors that I have the utmost respect for and supported me in a variety of ways of counseling me, telling me what they thought about the issues that I was asking about. They didn't shush me away, and at times I thought, people are going to think the only dense thing about me is my head, but thank God, they didn't treat me that way, and I just have very much appreciation, and I hope you all know that, and how much I appreciate it, because I think that a lot of people say, oh, it's great what you did, Addie, but I certainly did not do this alone. I knew the importance of getting input from physicians, because I needed to understand it. I needed to be able to speak about it in a knowledgeable way. And to do this, certain articles have been recently published that this has been done by lay people and so on. That certainly was not the case here. I don't know about other states, but certainly it was a lot of input, and I have the utmost respect for the 3 of you, so thank you very much. But anyway, let me see if I can find the clicker here. Let's see. Okay, here we go. So I just want to kind of give some background about the North Carolina breast density notification law that became effective on January 1st of 2014. And it started out as House Bill 467, but I'll get to that in a minute. I just have about 5 slides, so I'm not going to be very long, but I wanted to show you basically what breast cancer did to me within a few months. This photograph on this side was taken about a month before my diagnosis. And the next picture there was taken about 7 or 8 months later at the kickoff of the breast density awareness program
that was started by the Commission on the Status of Women with the City of Greensboro. At the time that I was, I had a mammogram about 8 months prior that was a clean mammogram, and then a few months later, about 7.5 months later, I felt a small lump, and I went to my doctor. They ordered a mammogram and a diagnostic mammogram and an ultrasound. And so I went in and they completed the tests, and after much discussion, they gave me the option of a biopsy, and we went ahead with that, and the biopsy revealed that I had invasive breast cancer, which was a big shock because I had had a clean mammogram just a few months before. Now, based on the size and the cell division rate and all of that, it was estimated that I had probably been there for about 3 years. And on top of dealing with a breast cancer diagnosis, to learn that it had been there longer than I thought was also a lot to deal with. But I started to talk to different people and learn more about it, and I found that what the issue that I was dealing with, it actually was pretty, I shouldn't say common, but the issue of breast density is something that affects a lot of women, probably about half the women in this room. So it wasn't something so unusual, but what I thought was unusual was that women in the state of North Carolina were actually, for the most part, unaware of this issue. During the time that we started the program with the City of Greensboro's Commission on the Status of Women, during that time, the American College of Radiologists put out a brochure to explain the issue of breast density, and I won't read it, but basically, as you can see, the last bullet point says that mammograms can be less accurate in women with dense breasts. I found all of this out after my diagnosis, not before. And I do actually joke around, that one time I remember one of the technicians had mentioned that I had dense breasts, but I thought that meant the girls still look good. I didn't really know what that meant, so, But anyway, I found out differently now. But anyway, one of the things my doctors advised me is not to go on the internet, but of course, that's usually kind of the first thing you do. But I actually didn't do that for several weeks into my diagnosis, but I was very careful. There's a lot of garbage on the internet, and so you have to be very careful what you look at. And I was really amazed by, this is Dr. Deborah Rhodes of the Mayo Clinic. She does a TED Talk that had actually gone online about a month before I was diagnosed, and she talked specifically about the issue of breast density and mentioned that only if you live in the state of Connecticut are you told about your breast density. So at the time that I started working on this issue, only the state of Connecticut had a law. If you lived in the other 49 states, it was kind of depending on where you went or that kind of thing, it may be mentioned. But so that just gives you kind of a visual of how many folks were probably not informed as I was. So I started working on this issue, and I want to acknowledge Gina Waters, who is sitting here in the audience. As you can see, we had very high-tech kind of visuals when we went to Raleigh to lobby for the state law. And this was the Senate health hearing. And I've never tried to pass a law before. I, didn't know what to expect or anything like that. But luckily, with the backing of the City of Greensboro, and the input that I received from physicians and other breast cancer survivors like Gina and others, we did a lot of hard work, and also compromised at times as well, because one of the things that we did differently here in North Carolina that Connecticut was successful with is we made a conscious decision not to include an insurance mandate in the law here in North Carolina. I spoke to a lot of different legislators and folks in the insurance industry that I'm familiar with, and I was told that if I wanted to include an insurance mandate as part of this law, it may take me about 30 years to pass this law. So I decided that maybe we would think about that at a later date. It wasn't that we didn't think about it. So I thought it was important to make sure that women were aware, but certainly I didn't want this effort to fail. So here is on July 23rd, 2013, Governor Pat McCrory, we became the 12th state. During the time that we were working on it, several other states were successful in getting the law passed. And so the three women on this side, that's Joy Cook, who was a commissioner with the Commission on the Status of Women, T. Diane Bellamy Smalls, who was a city council member at the time, Gail Foy, the chair of the Commission on the Status of Women, Governor Pat McCrory, and Gina, who is here again, kind of my partner in crime at times, but anyway. And I will say that the General Assembly, although there were a lot of contentious issues that year, this was passed unanimously by both the Senate and the House. Senator Gladys Robinson, Alma Adams were instrumental in getting this law passed. John Faircloth on the House side, instrumental in getting this law passed. This was a bipartisan effort that they all thought was important. So basically, where are we now? This is what the map looks like as compared to when I began my effort, where it was only, itty bitty Connecticut that had the law passed. Now, the pink are states that have enacted the law. The red states are bills that have been introduced. The blue states are bills that are currently in progress. The white states, there's been no action. And the black states, which is only a couple that have a little star there, are the laws that include an insurance mandate. So as you can see across the nation, a lot of states have chosen not to include an insurance mandate because that might be difficult. But I do want to say that Governor McCrory could have vetoed the law. In California, the first time around, the law was vetoed by Governor Brown because he stated that this could cause anxiety in women. And so anyway, that was something that I actually heard a lot of during the time that I was working on this. The concern from folks was that this would cause anxiety in women. The other concern that I heard from the lobbyist that was working on this as well was he thought that the fact that a lot of women in our community do not have insurance, and he was very concerned about this law because he was working with several radiology groups around the state of North Carolina, and he was very concerned about this. And I spoke to him about it, and I acknowledged that the issue with women that do not have insurance in our community here in Greensboro and across the state of North Carolina is a terrible issue. But I asked, should information like high blood pressure or I don't know, diabetes be kept from women that don't have insurance? I wasn't very clear as to why that was even part of the conversation. So I think that was a great conversation, and eventually we all were on the same page, and it was a great effort by a lot of folks. And at this point, I just wanted to also mention that Dianne Feinstein of California, back in July of 2014, introduced legislation to pass a national bill. So that is in process. It's a slow process, but it's been introduced, and there's advocates from around the country advocating for that. And the FDA is considering what's called a regulatory change. And so that's also been a very slow process. We're hopeful that if the FDA does do a regulatory change, that would change things and make it uniform across the nation. There were a few very large breast cancer advocacy groups that didn't necessarily go public and support me on this law because they felt that there was a concern of doing this piecemeal state by state. And I agree that that is a problem, because in reality, if this was a national standard, it would be a lot better. But unfortunately, that could take years. And in the meantime, we have right now 29 states. If you live in South Carolina, at this point, you are not required to be told about this. And I've become kind of the hub for women that contact me after they got their breast density letter and what do I do? And my answer is always the same: speak to your physicians. It is not my, and I'm so thrilled that we're here tonight because you're going to be hearing a lot more about that, but I think it's really important to speak to your physician. It is not my role as an advocate to decide what to do next, and there's a lot of, I think, questions about that issue. But I think we have elevated the conversation here in North Carolina, and I received so many emails and letters and things of people who have friends, and recently I received a letter from a woman, professional woman who lives in Raleigh. She's the head of a large museum in Raleigh, and she got her breast density letter in August and talked to her doctor, and she had several risk factors, not just the issue of breast density. She went in, they ended up doing an MRI, and she has triple negative breast cancer. She is undergoing treatment at this time. And she, and I'm trying to quote her here, said that she is living proof that this issue is important. I was a little bit disappointed. Recently there was an article in the Wall Street Journal about 2 weeks ago, and they interviewed, I get Google alerts whenever the North Carolina breast density law is mentioned anywhere. And so I woke up one morning at 6 a.m. and I see North Carolina breast density law mentioned in the Wall Street Journal. And it was like, wow. So I look at it, and they quoted a woman who said that she got her letter saying she had dense breast tissue, and she ended up having a biopsy, and it was nothing. And she would have preferred not to know because it caused her anxiety. And I'm not discounting that she felt that way. I'm sure she was being very sincere when she said that. But I thought, you know, you have another possibility of not knowing and walking around like I was probably for about 3 years. In the photograph you saw me looking very happy, not realizing that I had breast cancer at the time. So that's just my perspective, and I'll welcome any questions later on, but I will leave it at one last thing. One of my neighbors said this to me when she came over one day to bring me a pot of chicken soup, and it really stuck with me because she had her mother who had gone through breast cancer treatment and her mother-in-law. And she felt she was really informed, had never heard about this issue. And she said to me, you know, we're drowning in a sea of pink and we don't even know what to ask. So this is about awareness, and I hope you repeat this particular quote because it really stuck with me. So thank you very much for listening. And
Thank you, Addie. The legislature didn't have a chance. I understand there were several of them with broken arms, mysteriously found later on, but it was unanimous. And I'm very surprised to hear that I gave her advice. The only thing I remember telling her is, take the gun out of the house. So let's see. So this is the way those 2 acres of junk and mud are going to be looking, at least part of it. And the way you get to a garden is by doing the kind of work that Addie was doing. Now, the person that I'm going to introduce is Margaret Bertrand. Margaret studied in Baylor, and then she went on to Duke, and she has been a prime mammographer in Greensboro now for a few years. I cannot say how many years because that might be problematic, but a long time. She has been involved in every major development in Greensboro. And when I have a very difficult problem with mammography or imaging, Margaret is definitely one of the people that I go to. She also does a great deal of volunteer work, as you heard. So the question we've asked Margaret to address is exactly what is breast density? What does it look like? How do you measure it? Tell us more about it before we get into what to do about it. How do you define it? So she's going to tell us about that.
Good evening, ladies and other friends here tonight. I just thank you for coming out. I was proud and honored to have the opportunity to travel with Addie as an advocate and did testify in the House and Senate as to the value of letting women know they have breast density. That was an interesting journey, and I am so glad she asked me to go along with it. So now what I'm going to do is I'm going to take very long, but I'm going to kind of explain to you what makes a mammogram dense, what does that mean, and show you what it looks like. This is just a little diagram that I used my granddaughter's colored pencils to color in some areas. But basically, when you're looking at a mammogram, this is what you're seeing, only you're seeing it in black and white. The white represents several elements which we consider the glandular tissue, the ducts and the lining of the ducts, and the little lobules that surround the ducts. Then the black part is fat. The more fat you have in your breast, the less dense you are. So that, oops, I just got rid of my. So we'll see as we go forward. The breast on the left is a lot more black than that on the right, meaning there's a lot more fat. On the dense side, remember I mentioned that the elements that make up this density, some of it is just fibrous tissue, but much of the density represents glandular tissue. And I think when we sort of pull out why is breast density a risk factor, I think what we can sort of hone in, and I think maybe Dr. Brown will talk about it a little bit, there is in the women who are at most risk more glandular tissue. And the younger women who are undergoing lots of changes in the breast every month possibly have a little bit more risk of some of this tissue going crazy and producing breast cancer. Not every dense breast is at higher risk, and we'll learn a little more about that probably as the evening goes on. So the American College of Radiology grades the density, and we have just switched from going 1, 2, 3, 4 to A, B, C, D. And the reason is so that it's not confused with another thing that we grade, which is risk. Diagnostic potential for cancer. So as you go from left to right, you can see much greater density. The second one is average, and we can see still there's a lot of black in there. The third one, there's less black, a little harder to see. And then the last one is primarily fibrous tissue, some increased glandular tissue. And those are very, very hard to see breast cancer in because breast cancer is also white. Now, as radiologists, we don't give up on the mammogram, and that's a big takeaway from me, is even though it's harder to read a white mammogram, there are lots of the areas of dark, and we look in all of these spaces for abnormalities, and we're still able to see breast cancer even in dense breasts. It's just the detection rate is lower. So going back to the old system, roughly the proportion of the white or the glandular fibrous tissue is 25% or less in a fatty breast and greater than 75% in a dense breast. There's a huge difference between this and this, but just a gradient as you go down. Now, one thing that's different about the new method is that you see this one over here has a lot of black in it, And so if we were using the old system, it would have been a B. But in the new system, any area, if there's a large area that's white, we're gonna grade it C. So this is just a rough estimate. We don't use this anymore. So as you're going down the spectrum here, what triggers a dense letter? Half of the people are going to be this, the other half pretty much are going to be that. So when you go from this to that, from B to C, it triggers the dense letter. And our legislation basically is just an informational letter that lets you know that you have either a C or D density. And it is a little bit arbitrary, especially when you're going from A to C, because some radiologists on one day might think that it's a B, and another day they might think it's a C. So it's not a huge change to go from a B to a C, but it does trigger the letter, and it does trigger your brain to say, okay, now what you're going to hear about.
Dr. Bertrand, just to clarify, when you say dense letter, you're talking about the letter that people receive, not the classification. For people that don't know about what the letter is.
Right. That's why you come to this talk, so you can learn a little bit about the letter that you get does not go into that kind of detail. The letter that you get just says that in fact, it doesn't even actually say you have dense breasts. It says you may have dense breasts. And then it advises you, and it comments that it may increase your risk and it makes breast cancer harder to detect, and encourage you to talk to your doctor about it. So this is what we're looking at. We're looking at this tiny little area, slightly whiter, in a sea of white. And that's what we spend a long time learning how to do. It's back in the day of Highlights magazine, I was particularly attracted as a child to the what's wrong with this picture part. And I do this every day, all day long. So I hope I'm good at this. So this is my last slide, and basically you're going to see more statistics on this, but having dense breast tissue is not abnormal. It's not an abnormality. It's like a skin color or hair color or something like that. But you use caution. You want to make absolutely sure you have a normal breast exam. You want to review your risk factors with your doctor. And in doing that, you'll determine whether or not you're a good candidate for any additional testing. Not every woman needs additional testing. And of all of the new imaging modalities that have come to light since how many years ago we're not going to discuss, I started doing breast imaging, I would say 3D tomography is probably one of the best ones because it increases the sensitivity and it is more specific as well. And there are not many tests that we do that are both sensitive and specific. So Dr. Brown is going to be talking to you about 3D, but both centers do. We've been doing 3D for 1.5 years in Greensboro. We're among the first communities in the state to start that. And to just explain what it is, a screening mammogram that sees the breast in layers. And I think Dr. Brown has a little video she's going to show you about that. So that concludes my part of this, and
Thank you, Margaret. If you'll hold the questions till the end, we'll try to collect those. I just wanted to underline a few things that Margaret said. A young woman is more likely to have a dense breast. If you're 25 and you have a mammogram is likely not going to be very useful. If you're 90 and you have a mammogram, you may not need the mammogram, but it certainly will reveal a lot. So if your breast is dense at 40, it may not be dense at 60 or 70 as your breasts become more fat replaced. So when women go through menopause, the breasts change. So you don't have permanently dense breasts, although some women do. And women who took estrogen replacement for many years tend to have denser breasts, which may have contributed to their having a somewhat higher risk of developing breast cancer. So a very well-intentioned informational thing has led to now our having to classify more formally whether a breast is dense or not. And you're learning that science isn't what it seems. Science looks like it's cut and dried, but it isn't cut and dried. So you have your mammogram today, and you know, they had 2 cups of coffee and they said, oh my God, what a dense breast, and they call it a C. And then the next year you have the mammogram, and you know, he didn't have a coffee, and oh, it's a nice B, you know. Well, did my breast go from a C to a B? No, it's very hard to standardize this. Eventually, my guess is within a few years, very few years, we're going to have machines doing this. It's going to be read by machines. It's going to be much more standardized. But right now, it really is my eye versus your eye, and my eye today versus my eye next year. And it's problematic. So you should think in ballpark figures. So having said that, by the way, this is just another view of the garden you're going to have here one of these days. So now you know you have at least a C, maybe a D in your breast. Maybe you have dense breast. And now what are you going to do about it? In some states, as Addie said, you know, the insurance companies are forced to pay. They have to pay for an ultrasound. Does the ultrasound actually do anything? Do people follow the law? And the answer is no, they don't. Half the doctors, even in Connecticut, don't send people who have insurance for the additional ultrasound. So why not? What's the controversy in how to follow up with that? And to answer that question for us, which is a complex question, we have Dr. Elizabeth Brown, who's another premier mammographer in Greensboro, and another person that I absolutely lean on completely. Now, she does have a slight advantage, perhaps over Margaret, in that she went to UNC, but some of you might totally disagree and think it's the other way. And then she studied in Wake Forest, which is a terrific place to study radiology. So Margaret, Beth is going to tell us about what to do now you know that your breasts are dense.
Thank you, Gus, and thank you all for being here. It's really a pleasure to be with you all and just to talk about this important topic. I get a lot of questions about this. A lot of times I'll go and give a patient results and they'll say, I know you're worried about this mass in my breast, but what about this density letter I got? You know, so it is an important issue, and so I'm happy to share what we've learned about this. So in the United States, this is the general distribution. So about 10% of patients will have extremely dense breasts, about 10% at the other extreme, the almost entirely fatty. As Dr. Bertrand showed, that was the one with the very black breasts. The extremely dense are going to be the very white breasts at the other extreme. And in the middle, we have about 80% of the population, somewhere between scattered fibroglandular and heterogeneously dense, with all these shades of gray literally in between. And as Dr. Magernot was pointing out, it is so subjective. So it's like, you know, when you get to these little borders in between, it's like asking someone to walk outside and saying, is it sunny or cloudy? Well, that's pretty easy. But then when you say, well, is it partly cloudy or partly sunny? And how cloudy is it? You know, it gets fairly subjective, and it really does change from day to day, year to year, you know, whether the density actually changes. And truly the exposure and all those fine details related to the acquiring of the mammogram changes the presentation and the way it looks to us on the screens. And so it really can change dramatically depending on the unit, depending on lots of things. So we are talking ballpark figures at this point. So so this is the line that we've drawn separating the dense from the non-dense patients, and this is the letter that Melissa was talking about. So this is the letter in the US mail, not the ABCD. And so just to clarify, everybody gets a letter that says what their density is. It's just that the people on this left-hand side get a letter that say your breast tissue is almost entirely fatty, or scattered fibroglandular, not dense is what our letter says, or it says you have dense breasts. And this is what you need to do about it. So we're going to talk about what to do, but first I want to talk about what not to do. So don't panic if you get this letter. And number one, don't skip the mammogram, because just as Dr. Bertrand said, we don't give up on the mammograms, even in dense breast. And I think that's so important because mammography has really been the only screening tool that's been shown to reduce mortality by breast cancer by up to 30%, depending on the series. So it's significant, and there is never going to be another study that's been shown to reduce mortality of breast cancer that way. Ultrasound's not ever going to reach that. MRI is never going to reach that level. But mammography has been scrutinized forward and backward for years and years and years under very large volumes of patients, and it has proven the test of time. So stick with the mammogram, you won't be sorry. The mammograms are recommended annually beginning at age 40, regardless of density, because there are some things we can look for, as Dr. Bertrand pointed out. And there are things that we can look for, like calcifications and distortion, all kinds of things. So that's the most important message, I think, is don't skip that. So what the North Carolina breast density law does say is talk with your physician about this and other breast cancer risk factors. Together you can decide which screening options are right for you. And so that's the verbiage that's going to be in the letter if a patient has one of the dense categories. But there are no guidelines at this point that have determined who should be screened additionally or which modality we should use. So that's what I wanted to discuss tonight. And as Addie pointed out, in North Carolina, we do not have insurance coverage for these additional screening tests. So even if it's recommended, even if it is something that's important, your insurance may not cover it. So I think the two most important things to consider would be what are the screening options? Are they reasonable? Are they something that you would want to do? And what are the other risk factors? So let's just look at some of the additional screening options on top of the mammogram. So as Dr. Bertrand pointed out, we have digital breast tomosynthesis, also called a 3D mammogram. These are the exact same thing. So we use those terms interchangeably. But basically, the difference is, you know, when you have your mammogram, this little thing stays still at the top. But when you have a 3D mammogram, it sweeps across like this. It actually moves while you're in position there. So it does use compression. That's the bad news. The good news is that it does acquire this 3D image of the breast, and it allows us to look at the breast in layers. So when we sit down at the workstation, it's like watching a movie instead of just looking at the still images from the vacation. You know, you're watching the little cine. So it takes a lot longer to read. So honestly, I think that's part of the reason why we're better at reading these, because we're spending more time with the images. It's almost like you're walking through the forest and looking, oh, that was just a tree, that was just a tree, instead of looking at the whole forest from the road. You know, you really are stepping through that one layer at a time. And lots of studies have been done on this, and they show that we as radiologists do a better job of picking up the small invasive cancers in that setting, and also decreasing false positives. And these are going to be your false alarms. These are going to be the times we call you back and we say, you know, the good news is it was just overlapping tissue, there's no cancer there, and that's great to hear, but if we could avoid those altogether, that would be even better. So it does tend to do that. It does require special equipment. Obviously, this is not cheap, but it is increasingly accessible, and as Dr. Bertrand said, we have that available here in Greensboro, so it is here in North Carolina. We are some of the first sites here in North Carolina to have that. So this is an example of a patient that has very small cancer. I'm not sure that this will be easily detected without tomosynthesis. So this is the 2D mammogram, or the old-fashioned digital mammogram, which is not so old-fashioned, but this is the 2D mammogram. The cancer is actually right here. It's this tiny little spiculated mass. This is a single slice from her tomosynthesis exam, so you can see it a little bit better here, and I magnified it here, so this is that. And so this is just a single slice right through that area. So it's not presented that way, but we sit down and watch the little movie and stop it on that image and we can see that better. So if I can get this to work, we're gonna give it a shot. So this is a comb down, so I really kind of focused right on that one area. So we're actually looking at the whole breast at the time, but I really wanted you to see this well, so I just focused on that one area. So this goes through the mass 4 times. This might be a back of the room observation, but it's right in here, and it'll come back through it again. A couple of things right there. Do you see how it comes and goes? And the reason it comes and goes is because we're seeing different parts of the breast. So I'm going to do it one more time. I want you to notice there's some vessels here. There's even this part where these look like little polka dots here. That's the pores on her skin. It gets to that level where you can see the detail there. So let's do it one more time, because this is exactly how it is for us in the reading room. So remember, it's right in here. And you can see these are the little polka dots, the little pores in her skin. The vessels come into sharp focus occasionally right there. So those are the nice veins. Those are usually on the skin or close to the skin. Lesion is right there. So that's the kind of thing that we're doing. And so you can see why it takes us longer to read these, but it really does help us to detect these small cancers. And the important thing is in the research that they've done, it's not the small non-invasive cancers. And you would say, well, I want to detect all cancers, but we especially want to detect the small invasive cancers because those are the ones potentially more biologically active that might actually go on to grow up and do something someday. It's the non-invasive cancers that may or may not grow up to be important. So if we're going to find a cancer, it's the small invasive cancers that we want to focus on. So that's important. There's a lot of talk about overdiagnosis. And so if we had to choose, we would want to choose to pick up on the small invasive cancer. So those are the ones that is able to help us with quite a bit. So let's talk about some of the other screening options. So MRI obviously is a completely different modality. The patient lies on her stomach like this in this funky little thing called a coil, which allows the breast to fall through this little hole in the table. It uses no radiation, no compression. It is not affected by breast density or previous surgery or even implants. It does allow us to find breast cancer. It improves detection of that. And in a large series, it allowed us to find 8.5 cancers per 1,000 patients screened, and that was in a high-risk population. With MRI, there are false positives, and if you scan a lot of patients that have lower risk, you're going to find more false positives, and that's true for any screening study. But so some patients did have an unnecessary biopsy because of it, sort of like the patient that Addie was talking about. So you have to think about that when you're screening. You keep screening a lot of people, you're going to find more ditzels, more nothings that are going to require a lot of workup for a little benefit. So it's a fine balance that you have to strike there. So it does require IV contrast, so you have to have patients with healthy kidneys. So patients without healthy kidneys are not good candidates. Patients that have claustrophobia can't always go into the scanner. Sometimes we can help them overcome that to get into the scanner. And some pacemakers are not adequate for the MRI scanner. They're not safe to use with the scanner. So it's not for everybody. I did want to mention fast MRI. This is not ready for prime time, but it's promising. And so in a recent study, this was just a proof of concept study. What they did was they looked at patients that had dense breasts regardless of their other risk factors, and that's kind of the population that is very interesting, I think. And so what they did was they just looked at the money sequence on MRI. I don't know if any of you have had an MRI, but if you'll remember, you're in there 35 minutes and you're wondering, what are they doing? And this one lasts about 5 minutes and this one lasts about 7 minutes. And so it knocks around for a while and you sit there. But what they're doing is different sequences, and all of those tell us different things about the tissue and what it looks like. Water looks like something on one, and cancer looks like something on another. So we add all that together to help us But what they do is they just go to the money scan, and we can't really characterize things, but we can say, is it positive or is it negative? Do we need to look further or not? So that is a promising study. It would still be a fairly expensive study, and it still has some of the same limitations that we talked about earlier. Breast ultrasound is another modality that is important when we're talking about breast diagnosis. For screening, it was very promising at first. There was quite a lot of talk about using universal breast ultrasound for screening of patients with high risk or high density. And it does definitely detect additional cancers at a rate of about 3.2 per 1,000. It is not as sensitive as MRI, and it does have a high number of false positives. So if 10 patients had the screening ultrasound, about 1 out of 10 underwent an unnecessary biopsy. So it is a pretty high, maybe unacceptably high rate of an unnecessary biopsy after having a screening ultrasound. So, and this is with a handheld ultrasound probe like this and scanning. It takes a lot of expertise to do this. It's a very user-dependent study. You need to have a lot of training to know how to hold the transducer. You can't just mow the yard and scan all the quadrants and say, I'm done, and turn in some images and hope that someone knows what to do with that. You're interpreting the images as you go, looking at everything, and so that's a really difficult exam to do well. So the other problems with this is just having qualified personnel that are available to do it. So this is going to be a difficult screening study, I think, to implement. This is what your images may look like if we find something on a breast ultrasound. Of course, we use breast ultrasound every day when we have something that we want to target and really focus on. So it's vital to what we do. But we use it more in the diagnostic setting than in a screening setting. So I think we may see more from automated breast ultrasound. And here what the tech is doing is there's this paddle sort of thing. And this is a technologist that's well trained, so it doesn't have to be a physician. And she can go in and acquire several projections, almost like a mammogram, and acquire a 3D data set that can be turned in, and a physician can sit down at a review station and look at all the images and say, oh, there's a little area of concern there in the upper inner quadrant. Let's bring her back and let's look at that further. So it's kind of a different beast altogether than what we saw earlier. It's similar to the other kind of ultrasound in that there's no radiation. It does do a little bit better job of standardizing the projections and the images that are acquired. We still don't have a lot of great trials to date on this, but there is some early data, so we'll keep an eye on this one. Also, a word about some of the emerging techniques in functional breast imaging. Molecular breast imaging involves injection of a radiopharmaceutical that then goes into the body and highlights areas of abnormality, like in this case. So the projections are kind of similar to the mammogram. And the good thing about this is that we can scan some patients that have contraindications for MRI. So if they have a pacemaker or claustrophobia or poor renal function, they still may be candidates. Some of the concerns regarding radiation dose are being addressed, and so there are some good trials that are going to lower that dose and hopefully make it a good screening tool. So that, I think, may have some promise there. Also, something called PEM, or positron emission mammography. These are all something to keep an eye on, but this one is fairly expensive at this point, not readily available. But basically, it also involves injection of a radiopharmaceutical into the body that gets taken up by the breast, and then the breast can be imaged, and these color map images can be acquired that show where the radiopharmaceutical is within the breast. So it's almost like you're doing a slice through the breast. So also involves a fair amount of radiation and is an expensive exam today. So these are not ready for screening at this point, but something that, who knows, maybe down the road will be. So I think the second big question that you need to ask yourself and your doctor needs to consider is, what is the overall risk? So we talked about some of the screening types, but I think you need to think about the overall big picture. And so to do that, I think you need to look at all the risks, not just breast density. And so I think you just need to kind of get some perspective on that. And so to do that, I thought we'd run through some of the risk factors. And this is not an exhaustive list, but in general kind of starts with a higher risk and goes down. So obviously gender is one of the stronger risk factors, where females will get breast cancer about 100 times compared to males getting breast cancer, so definitely a high risk. As patients age, they tend to get cancer more frequently, and 2/3 of the cancers are found in women over age 55. Genetics appear to account for only about 5 to 10% of all breast cancer. We think about genetics being such a high risk factor, and it is, but we've got a lot to learn about the other causes, I think. BRCA1, BRCA2, and there's some other genetic mutations that we talk about. Family history is also important, but this is often a surprise to a lot of people, is that less than 15% of all breast cancers occur in patients with a family history. So most of the breast cancers diagnosed are in patients that have no family history. And so, I have patients all the time that tell me, I'm sure this biopsy is not going to be anything because I don't have any family history of it, but it's not protective. So if you don't have a family history, it's not going to protect you. So still get your mammograms and follow up. So if you think about family history, if you have one first-degree relative, meaning like your mom or your sister or your daughter, you have 2 times the average risk of breast cancer. If you have 2 first-degree relatives, the risk is about 3 times. Of course, if you have a personal history of breast cancer, you do have a higher risk of recurrence, and that's about 3 to 4 times the risk. Prior chest radiation for previous cancer probably should be bumped up a little bit on the list, especially for Hodgkin's lymphoma, especially performed early in adolescence. So those patients are actually pretty high risk. There are also these things we do biopsies for that come back, and we call them high-risk lesions. And you would probably know if you had one of these, but they usually have this word in common, atypical. So we would say it's atypical lobular hyperplasia or atypical ductal hyperplasia, or something called LCIS, which is lobular carcinoma in situ. So these are some lesions that when the pathologist looks at them under the microscope, they say that is what this is, and they either put you at higher risk for breast cancer at that spot or somewhere else in the breast. So breast density, of course, we've talked about that one, and I'll talk a little bit more about the risk involved there. And Dr. Magrodot also touched on this one, hormone therapy after menopause, especially combined estrogen and progesterone therapy. And then some, we're getting down towards the ones that are not quite as strong, but delayed childbearing, early menarche, alcohol consumption, that's the bad news here. So any alcohol actually does increase the risk slightly of breast cancer. Obesity increases the risk. Race is kind of interesting. Caucasian women are more likely to get breast cancer, but African American women are more likely to die of breast cancer, and the types of cancers that they get can be different as well. So it's a kind of mixed bag there. So as far as breast density goes, we had talked about heterogeneously dense being about 40% of all women. It's a normal thing, but it just does increase the risk slightly. It ends up being about 1.2 times the average. And for patients who have the extremely dense category, they have a relative risk of about 2 times average. So if you wanted to compare it to something else, it's similar to the risk of having a first-degree relative diagnosed with a postmenopausal breast cancer. So when you're looking at that family tree, you say, well, just pretend you have a sister that was diagnosed with postmenopausal breast cancer, and that's similar to the risk if you had that extremely dense category, which is actually fairly uncommon. So I wanted just to present a couple of decision trees, which I think can kind of help you get your head around what to do with all this. So if you have dense breast, you get the letter that says you do, then you can kind of just take a step back and say, well, there's really no family history or any of these stronger risk factors, and I'm not talking about, delayed childbearing and some of the ones at the bottom of the list, but none of the ones really at the top, and no risk factors here, then it's probably appropriate just to have routine screening, I would definitely consider tomosynthesis because the gains for us as radiologists in improving the mammogram when we look at a 3D mammogram are better in a dense breast than a fatty breast. So it makes it a better test, especially in patients with dense breasts, is what the data is telling us. But if you go down the other half of the tree and you start to look at your risk factors and you say, well, you know, I do have one first-degree relative that had breast cancer, and I might have some other of those positive risk factors as well. Let's start thinking about doing something else. And so that's something else I would suggest starting with is this risk assessment. And there's several statistical models that are available, and they account for some of these higher risk factors that we were talking about. None of them are perfect, so what you try to do is pick one of the ones that's going to include some of the factors that you know your patient has. And I will tell you right now, none of them has the density included in them. I think they're trying to tweak some of the current models to include breast density, but currently none of them include that. So you just kind of have to do your best with assessing that as a risk factor. So these are some of the currently available models, and we have computer-based models for a lot of these that are available in our office. This is one that we use a lot. It's called the IBIS. And so you can see it's, you just kind of go in and plug in what you do know about the patient. Her age is 40, she had a menarche at 13, she's 5'5", she weighs 140 pounds, you know, who was diagnosed with breast cancer, her mom and her paternal grandmother. I just totally made this lady up. And she had 2 sisters, one with breast cancer. So what does that do to her risk? And so this is what it spits out. It says that she has a lifetime risk of 42.2%. Well, that helps us a lot because that tells me that the American Cancer Society would recommend doing something else with her, and I'll show you that. So I think we included this slide hopefully in your packet. I think this is a pretty important one because, as I said, there's very little guidance on what we're supposed to do with patients with dense breasts and high risk, but this is one of the areas where we do have some pretty good guidance, and the American Cancer Society has said this is what they recommend. And really, the clear guidance is on this arm of the tree. So if you do that risk assessment and you come up with greater than 20% lifetime risk, what the American Cancer Society recommends is an annual mammogram plus annual MRI. And to get to greater than 20% lifetime risk, I've run a lot of these profiles. You really almost need 2 first-degree relatives, or you need a very young patient that's going to have a lot of years to accumulate that additional risk. Just to throw that out there. So an aunt or a grandmother is probably not going to put a patient in this arm. Now the middle group here, this 15 to 20% lifetime risk, is considered sort of an intermediate risk. And the American Cancer Society has no current recommendations for or against MRI. So they're not really taking a stand on this. And this is where you just really need to talk to your physician, consider other risks. You know, how do you feel about this? Is it really important to know? Do you want to do 1 MRI? You don't have to do it every year. Would, you know, if you're at 19, would it be appropriate to do 1 MRI, or you wouldn't have to do any? You know, there's no recommendation. So I think it's just very important where your decision-making process comes into play here. And down here, this is not considered low risk, but average risk, where you have less than 15%. So this is where most patients are going to live. This is a patient who doesn't have a strong family history, and the American Cancer Society clearly recommends against MRI for these patients. And the reason for that is what we talked about earlier. If you screen a lot of patients, you're going to find too many dentals, too many things that are going to require a lot of workup. It's going to be expensive for the patient. It's going to cause anxiety, offer very little return. So it is important to make sure that you kind of keep this tree in mind as you look at yourself. So this is what I would consider, though, in a patient who is on the far right-hand side, the intermediate or average risk patient, plus dense breast. So I would definitely recommend annual mammography if I haven't said that already. I would definitely consider tomosynthesis. As I said, it does improve our detection. I would always keep up with annual physical exams and monthly self-breast exams. And I would carefully weigh the options of MRI, especially in this intermediate risk category, understanding that it comes with cost. Potentially insurance wouldn't cover it, potentially involving additional exams like an MR guided biopsy, which is not cheap. But if we find something, we're going to want to find out what it is, and you are too. Ultrasound, routine screening ultrasound is not currently recommended for this group. And I think this is really not talked about very much, but there are some risk factors that we can modify. You know, we're not just locked into our genes, you know, so there are some things that we can modify, like weight and alcohol consumption and physical activity. We can optimize those things and do something about those risk factors. So just to kind of summarize, annual mammography is recommended beginning at age 40, regardless of density. We don't give up on you, like Dr. Bertrand said. The dense breasts occur in up to 50% of all women. It is a normal finding. It does slightly increase the risk of breast cancer, depending on the degree of density. As we said, the extremely dense is about 2 times the risk of breast cancer. And I think you should consider breast density in the context with all the other risk factors. And if a patient is interested in additional screening, I would look at those other risks and see, is that something that is reasonable? If the patient is in the highest risk category, I do think MRI is the right thing to do. Other categories, I think it's less clear. In the lowest risk category, it's clearly not the thing to do, a screening MRI. And I think for patients in the majority of the lowest risk, the average risk patient, it's probably appropriate not to do anything additional except for maybe a tomosynthesis and all those other good things we were talking about, the breast self-exams, you know, the routine physical exams, and optimizing the other risk factors. And stay tuned. I think the other studies hopefully will help us answer some of these questions. I do think we'll learn more about the 3D ultrasound. I think that will hopefully add some value to the ultrasound, because it clearly does detect additional cancers, and hopefully without so many callbacks and a more standardized approach. I think that was my last slide. Hope that gives you some direction when you're trying to make all these decisions. I know it's fairly complicated, but it's an emerging area, and I think we'll all learn a lot as we go forward. So I think we're down to Q&A, and
I'd like the panel to come up so they can take questions. So I'm sure we've all learned a lot tonight, and we'll be glad to take your questions. But one thing that's so striking to me is that things don't stay still. You know, 3 years ago, you think you know something, and then people start developing new technologies, and perhaps ultrasound is not so good, but what if we standardize it, you know, in some way? MRI is very expensive, it takes a long time, but what if we do a mini MRI? Perhaps that's the way to go. There are lots of studies, really literally dozens of studies using the radiopharmaceuticals that hopefully are only taken up by the cancer, so you don't need to receive that much. So it lights up like a light bulb in your mammogram. And all this is happening, and 6 months from now there could be a landmark study that changes everything. So you could hear the story every year, and you would hear a slightly different story every year. For the physician who is dealing with a patient, I think I would back off even further. And Beth tried to put the density in the whole set of risks. But you know, breast cancer is not the only risk you've got. Many more women die from heart disease than breast cancer. And you know, if you drink a little, that's good for your heart. People who drink moderately live longer than people who don't drink. So what do? You drink moderately for the heart disease? Yes, you know, that is what you do. But you know, you don't drink as much as you might because of your concern. But so this is, you have to put it in the whole context of everything. But for a physician, it becomes very difficult. I don't have a simple answer to my patient. If the risk is really high, we really go for the MRI. It's the very best test, and we just deal with the false positives. But it's $2,000 in insurance frequently doesn't pay, and how many patients have $2,000 every year that they can just fork out. That says, even if insurance pays and you pay 20%, that's $400. That's beyond many of my patients. They cannot afford that. The tomosynthesis is relatively inexpensive. I really recommend that. It's a good investment. Why doesn't insurance pay for that? Insurance should pay for that. So to me, if we're going to lobby for something, that would be the very next step. That every insurance company ought to be paying for tomosynthesis on a routine basis on every patient. But that's my opinion. Questions? Melissa's going to help.
May I make one comment about the insurance and tomosynthesis? Medicare is paying for, most Medicare policies are paying for tomosynthesis now. And there is a code that we can use for the other payers, you know, Blue Cross and so on. But we are finding that they are not always covering it. And so I think it's going to evolve over this year. I think we'll have a better feel for exactly how insurance is going to cover tomosynthesis. But if you know somebody in the Medicare age or in Medicare, it's definitely covered in a screening mammogram for tomosynthesis.
Oh, I was just going to say, hopefully the insurers will follow suit, because usually the first step is Medicaid, Medicare, and then hopefully they'll fall in step. But it's important that, you know, your insurance companies hear from their patients and their clients, because that's how they make their decisions.
I'm giving you the microphone because we're taping and we want to hear the question.
Just wanted to ask maybe Dr. Brown about breast thermography as a screening method.
Good question. So the question is about breast thermography, and it is not an FDA-recognized modality for screening for breast cancer. What it does is it detects small differences in the skin temperature of the breast, and so the hope is that there's a lot more blood flow into that area, and so it might make it a little bit warmer, so it might be detectable that way, but it really hasn't proven to be a good method of detecting breast cancer. And if something is detected, the first thing they do is send a patient for a mammogram to see if we can characterize it better, and full ultrasound and that kind of thing. So it's not in any way a substitute for mammography. Good question.
There was a study that was done for mammography in the 70s, and thermography was initially included in that. Later it was dropped, and it really did not show itself in a scientific study to be very helpful in the detection of breast cancer.
Questions?
My question is, does microcalcification have anything to, is it related to breast density? Does it show up in less dense breasts, or how does that fit into this picture?
Great question. We can both answer. Microcalcifications are very common in the breast. They can be in either benign processes or malignant processes. The reason we care about them is because they do sometimes show up in breast cancer. And the good thing about calcs is that they do show up regardless of density. So especially with digital mammography, it really helps bring those calcifications out so we see them nicely. And some of the algorithms used for 3D tomosynthesis even pops them out better. So I do think that the detection of calcs is really sort of independent of the density of the breast. That didn't used to be the case so much with old analog mammograms, but I think they've just gotten better and better every year. And then what we do is we detect them first, and then we try to characterize them to see if they look suspicious in any way, because there's so many different patterns, and that's what we're looking for, is to see if the pattern is in any way suspicious. There's a lot of overlap between benign and malignant calcifications and the patterns they might have. So sometimes we just have to biopsy to tell what's what, and but sometimes we can really tell just by their pattern what's going on.
And many things can cause benign calcifications, from trauma to just being, and that, you know, it really isn't all, I mean, pattern is what we're looking for, but we don't always see the pattern that we think we're going to see. And if you take all comers of ladies who have biopsies for calcifications, depending on the center, about 1 in 3 to 1 in 4 will be cancer and the others will be benign. So there's some very definite patterns. We see that and we go, that's cancer. We almost don't even need to biopsy it, but of course we do. And then there are a lot of random calcifications. So it's what's wrong with this picture again? What looks different this year from last year? And if you really want to see a difference, take this year's and compare it to 2 or 3 years ago. So that's what we do, as I said, all day long, every day. We're looking for that tiny little bit of change.
I have a question about qualification for 3D procedure. As soon as I got my letter, about 2 weeks later, I started getting all kinds of brochures and advertisements and everything. Come to this center, go to that center, we do 3D here. And I just want to know, is there any requirements for further education for that procedure, for the technologist doing the procedure, as well as the physician interpreting that procedure? And how can you tell if one facility has the certification and another one may not, although they may have the instrument to do it?
To be able to operate it, you have to have the accreditation through the FDA or MQSA is what we call it. So if they are operating, they are accredited. The staff has been trained, the radiologists have been trained, and there's fairly strict requirement of 8 hours of extra training for the radiologists. Most of us have taken more than that in other workshops. And then the application specialist comes in and spends, is it 3 days? At least 3 days with the staff, training them on the unit, and then actually doing patients. The applications people are still here while we're doing our first round. So yes, there is considerably extra training, and the thing you can rest well about is that any facility advertising that they do it has already gone through that.
Anybody else? These are good questions. Darn it, I just walked.
Did you wear your Fitbit? You need all those steps.
Did you see me walk through that wall back there? I went outside and came back in. All right.
I know that UNC Chapel Hill their hospital has a high-risk breast cancer clinic, I guess is what it is called, which my daughter goes to. I was just wondering if there is a similar program here in this area.
Yes, we have a high-risk clinic. The problem is we lost one of our 3 breast doctors about a year ago, and the remaining physicians have been somewhat swamped. But Dr. Khan has been specially trained to do high-risk counseling in breast cancer, and we got a geneticist just to help her with that. Within a year, there were so many referrals to the geneticist, not necessarily for high risk, that now we're going to have 2 geneticists. But we still need the 3rd doctor, so we're still looking for a 3rd breast cancer physician, hopefully by the end of this year. But the answer is it's there, but it's a little weak right now because we're swamped.
Thank you.
Oh my gosh, I hear so many questions. I know you people have more questions. It's fun.
Just out of curiosity, do you think that the 3D mammography would be present today if the issue of dense breast hadn't come up and been so heated?
I do. It's a technology that's been in the works for years. It's actually similar to what used to be done back in the 70s to look at kidneys. So it's a technology that's been developing for a while, but I think the timing is interesting because I do think it adds a lot to the evaluation of dense breasts.
And I would like to make a comment. We have found that the 3D tomosynthesis helps all women, not just women with dense breasts. Where I forgot, but I think that case you showed was not a super dense breast.
Yeah, you're right.
Yeah, I think she was average, and we're amazed by that. I mean, we are totally amazed. So I think it doesn't add quite as much in the fatty breast, but we'll recall a patient with a fatty breast that's gone through screening. It's just to do a 3D on her because and we found some very small important cancers even in fatty breasts.
But I'd like to address what you're really asking is, how has technology addressed this particular question? And when you see an automated ultrasound coming, that seems to me is specifically designed for this. There's always technical advances. You know, digital mammography came in how many years ago? It's 3 or 4, not that many. And insurance didn't pay for that. You had 10 years ago. They weren't paying for it. You had to have the films. And patients had to pay extra to get digital. So the tomography is more in that line. It's just continuing that line. But when I hear these other things that are more automatic, we need an automatic way of figuring the breast density. I mean, you didn't even worry about it before. Now you're going to have a machine to tell you because the radiologists themselves can't agree. Yes, so there's technological development that is being driven partly by this movement, if you want to talk at it more.
Thank you very much to all of you. I don't know if you can answer this question, but it seems to me that definitely technology is going much faster than what is approved by government and insurance to save lives. How long does it take for an FDA test, for a test to be approved by the FDA to actually go to the route of being available to the patient? As I say, I don't know if you can answer that question or not, but it seems to me like a lot of lives could have been saved in the meantime.
So what I'm hearing is, if these were guys, they would be saying, is it over? But what I'm hearing is, you mean it takes years to get this passed? What's wrong with them? Well, you need to get in there and push. You need to start, banging the arms,
I'm sorry, how many studies? What's the population that they need to reach in order for this to become, oh yeah, I think this is something that we need to consider now.
I wanted to mention, I've read a lot of studies, and one of the biggest predictors of mammography failure, and let me clarify, I went from my mammogram. I certainly advocate for women continuing to get it because it saves lives. But I read a study that was published in the Journal of, I have it in my purse, but it's a study that was published in 2000, saying that the biggest predictor of mammography failure is high breast density. And that was in the year 2000. So sometimes it takes years for things to trickle down to women that need the information. I think, as a community, there's a lot of questions. And unfortunately, we may leave here with still more questions, but I think we've elevated the conversation when it comes to this. You mentioned the FDA. When I was diagnosed in 2011, the FDA was considering a regulatory change on this issue then that would have made it unnecessary for me to advocate for a state law. I wish that would have happened. But that's why we've done it piecemeal, state by state. Every state has a little bit of a nuance that's different. In this state, when I originally drafted the verbiage, I did not include the word may in there. I wanted it to be very specific, but, you know, there was a concern that women may get scared, and so they included the word may, you know, you may have dense breast tissue, which, you know, I thought was, well, you know, but that's the kind of thing, you know, as women, that we, and it can't just be one person, it has to be a lot of people. And I wanted to, by the way, while I'm speaking, is that I don't have my glasses on, but I wanted to acknowledge a woman in this city that had a tremendous effect on this becoming a conversation. And Sandy Neerman, if you could wave back there, I'm thrilled to see you. And Sandy Neerman was the assistant city manager for the city of Greensboro, and I think she retired partly because I drove her crazy. I'm not really sure, but anyway. But, you know, I just wanted to thank you, Sandy, because it took a lot of people believing in this. The city of Greensboro is the first city in our nation to support breast density legislation before it became a state law. So thank you. So sometimes it takes a village, you know, where this groundswell that's happening around the country, eventually I think good things will come of it, that new technology will be driven, and better, you know, screening modalities and just better information for all of us.
When you say to push, Dr. Magrat, do you mean call our insurance companies and say, explain the situation? You know, I mean, is that what you mean by push? Because they're getting smart. And in my case, with my triple negative, and that had been in me for 2 years before I was diagnosed, and it was only 2 months shy of my next mammogram, and it was 3 centimeters growing at a 99% rate, which doubled inside of 2 weeks. So, I mean, so in my case, they figured out that with triple negative reoccurrence, you don't survive because there is no cure for it. So they wouldn't do my PET scan this particular year, and I'm a 4-year survivor, because they realized it won't help her to find it sooner, but she's going to die anyway. We don't have a cure for it. So I want to know, what can I say to them? And I will say anything.
Go stand in the hallway.
You know, people actually go to courses to figure out how to do a good job of this. I think you have many women here. You know, Addie is a great example who are very experienced in how to move things along. But these are bureaucracies that really don't have your health in mind. That's not what they have in mind. What they have in mind is the bottom line. And they're very, very good at looking after that. Your health, you know, is part of the equation, you know, but it's only a little part of the equation. So if you want to make it a bigger part of the equation, you really have to go to the top, and you have to push at the top, and you have to get political. That's just the only way you can do it. It's a lot of work, and it can be unpleasant, but otherwise, nothing happens.
I wanted to also mention, talking about tenacity, one of the things that I have rarely mentioned was the Centers for Disease Control changed their risk factors, because I would contact them almost every day via email for months. And one day they emailed me back, and I was like, so they said it will be changed shortly, and like the next day the CDC included breast density on their national website, you know, and that was just emails. And so, you know, it's pretty amazing that the CDC changed their, not changed, this was risk factors that were included with the American Cancer Society, with multitude of other very well-respected organizations, you know, numerous healthcare facilities around the country, including Mayo, and all of them did list breast density as a risk factor, and the CDC didn't. And so I asked them, why not? And, you know, people look upon you to, you know, get information, and they finally did. So, you know, question your insurance company. And I'm curious, have you all heard about a lot of women being denied, maybe if a woman has some major risk factors, you know, have you seen a lot of women get denied by their insurance company, that they have to pay out of pocket? Or so that's unfortunate.
Yeah,
But
even women diagnosed with breast cancer.
Wow. You say that's not acceptable. So
Yeah.
I think we're probably going to have to stop, because the women here need to get some work done, I'm sure. after they get home and look at some more mammograms. I just wanted to say, when I was in medical school, we had a radiology lecture, and they put up a chest x-ray that looked completely black. And then they started telling me all the things you could see in there. You know, the COPD and the enlarged heart, you couldn't see anything. It was all black. And these ladies see things that no one else can see, even when they're magnified. And they pointed out, you said, is that really a cancer there? And so I just wanted to say, we're lucky to have, you know, the people who help us get to where we are tonight, like Addie, and also the people who really let us find the cancer so we can treat them. So, a hand to you.
Very quickly, I forgot to ask this question, and I was really curious. And so if you would raise your hand if you are a breast cancer survivor, meaning if you've ever been diagnosed with breast cancer, you're a survivor. Well, there you go. Then would you raise your hand if you found a lump that sent you in for a further testing, that you would say you found your breast cancer yourself? Okay, and I only say this because Dr. Brown mentioned doing the annual self-breast exam as part of your protocol for breast health, which is obviously a great idea. But I hear women all the time say in support group that they have found their own breast cancer, and it wasn't doing technically a breast exam, you know, what might be considered what's hanging on the card in your shower that you picked up at a breast event. It was, I bumped into the side of a cooler in the backseat of the car, or you know, my spouse found it and I screamed, or whatever. So I just want you to, in addition to taking home all of this information, be aware of your own breasts. If you're not somebody that's had breast cancer, even if you are somebody, you know, that to me, that's something that, just from what I hear from women who have had breast cancer or not, this is really important to know your body. And in addition to having the mammograms and doing these other proactive things that they've suggested that you do. I just wanted to add that because I feel like that is something that if you find, if you think you have a problem, follow up with that.
Yes.
All right?
And that's part of the theory behind the notification letter, is that if you had a little something, then you get, but I had a normal mammogram. Then you get, it was normal but dense, you need to take it one step further. You know, have your doctor check you, have a discussion, and so on.
Addie knows this. I had a clear mammogram, and 10 weeks later I had stage 3 breast cancer, much like Addie. So it definitely is something that you need to pay attention to. Feel your breast, feel your breast, feel your breast. I say it all the time.
Yes.
I want to also tell you on your program that if you look at the back page, it says save the date. That will be our next Alight Night, which is Thursday, April the 30th. And it's genetics and breast cancer, what you'll risk. And this is something I think that would be relevant for many of you because you've had breast cancer, so you'd like to understand perhaps for your children, your family members. So please feel free to share that information and invite other people to come with you for that. Dr. Kahn will be presenting that with Karen Powell, who's our genetic counselor here at the Cancer Center. And I hope to have a couple of patients who have had prophylactic bilateral mastectomies that didn't even have a cancer diagnosis, just because of the strong family history and first-degree siblings that had had cancer. Does anybody have any other questions before we wrap up tonight? I can't thank you enough for coming. It's been great, and I'm so pleased that we had a topic of such great interest to you. So thank you all for coming. Thank you all.